This video will demonstrate the appropriate technique used to provide adult oral intubation using direct laryngoscopy. Devices are now available to help with this skill, including bougie tube introducers and video laryngoscopy. For this demonstration, we will be using a standard laryngoscope and ET tube. For specifics regarding advanced techniques and alternative devices, please refer to your medical director or training officer. It is also important that the EMSP have a backup airway prior to attempting intubation should a failed attempt occur. Backup airways should include simple adjuncts and/or blind insertion airway devices. Ensure that patients do not become hypoxic. Always resume ventilations with bag valve mask devices on supplemental oxygen should attempt to be greater than 30 seconds or failed. Please ensure that all equipment is available and within reach prior to stopping bag valve mask ventilations and attempting oral intubation. Indications for oral endotracheal intubation include cardiac arrest, inability to ventilate using conventional methods of BVM and simple adjuncts, and airway collapse. Patients that are responsive with intact gag reflex should not have oral ET tube placement attempted. It is imperative that the EMSP provide appropriate post-intubation ventilation and monitoring. Gather all necessary equipment to perform this skill. Equipment should include oxygen, suction device with appropriate catheters, BVM with mask and reservoir, airway adjuncts, laryngoscope handle and blade, ET tube with stylet in place. Stylet is not to exceed beyond Murphy-I. Capnography device and a commercial securing device. Tape is acceptable if approved by medical direction. Special note, blade and endotracheal tube should be appropriately sized for the patient. Blade type is user's preference. Begin by taking appropriate body substance isolation precautions. Ensure your patient is being pre-oxygenated via bag valve mask with high-flow oxygen therapy and simple adjunct in place. Attach syringe and test cuff inflation. Be sure to remove all air prior to insertion. Ensure blade bulb lights up and is securely attached. Once all equipment is readied and pre-oxygenation has been accomplished, stop ventilations and remove the simple adjunct as necessary. Position the head in the sniffing position with the head slightly elevated. Ensuring proper alignment will increase the chance of successful intubation. Insert the laryngoscope to the appropriate depth for the specific blade. Miller or straight blades will elevate the epiglottis directly, while the Mac or curved blade should be guided posteriorly down the tongue with the distal tip of the blade being placed in the vallecula. Upon insertion of blade, sweep the tongue to displace and elevate the mandible. The EMSP should take great care not to rock the blade or use the teeth as a fulcrum. Upon visualization of the glottic opening, take a mental note of the view to classify for documentation. Accepted standards include the Cormack-Lehane scale and the percentage of glottic opening scale. For specific recommendations, seek advice from your medical director. Insert ET tube and advance to proper depth. Cuff is just slightly distal to the glottic opening. Inflate the cuff and immediately remove the syringe. Begin ventilating the patient through the endotracheal tube and begin confirmation. Initially, confirmation should be done by visualization of the tube through the cords and auscultation over epigastrium and bilaterally over the lung fields. Remember to maintain a continuous hold of the tube until the proper securing technique has been achieved. Continue verification through multiple measures. 1. Condensation noted in the tube. 2. Visual chest rise and fall. 3. Esophageal detector device. This should be done prior to first ventilation. 4. Colorimetric device. Remember to take into account low perfusion states such as cardiac arrest, as colorimetric devices may not indicate proper or improper placement. Secure the tube once confirmation has been achieved and monitor for hypoxia during the intubation attempt. It is recommended that the EMSP use a commercially available ET securing device as shown here. Begin ventilation at the appropriate rate and volume. Attach patient to continuous waveform capnography. Continuous waveform capnography should be the gold standard for confirming tube placement and monitoring during transport. It may be recommended by medical direction to place continuous waveform capnography as soon as the tube is placed and prior to the first ventilation. If a waveform is seen on the monitor, the tube is in the trachea. If no waveform is noted and a flat line is seen, the tube is improperly placed or has become dislodged. Critical interventions for adult oral endotracheal intubation will include: interruption of ventilation should not exceed 30 seconds. Ensure access to backup airways prior to attempt should a difficult or failed attempt occur. Continuous monitoring with waveform capnography must be ensured. Remember, no waveform, no tube. Ventilate at appropriate rates and volumes. Monitor hemodynamics throughout transport. Tube should be strictly held in place until acceptable means of securing are assured. Moving a patient warrants verification to ensure the tube has not become dislodged. For the second part of this video, we will discuss the techniques necessary to perform suctioning through the previously placed endotracheal tube. Prior to suctioning, ensure that you have sterile water or saline available to clear the flexible suction catheter after suctioning. Recognize the need for suction, including excessive secretions, mucus obstruction, or vomitus in the endotracheal tube. Ensure ventilations are continued while preparing to suction. Select the appropriate flexible suction catheter and attach to suction. Turn suction to appropriate setting, normally no greater than 80 to 120 mm Hg, and kink or occlude the distal tube to ensure suction is applied. Measure flexible suction catheter. Begin by placing the distal tip of the suction catheter on the sternal notch and hold in place. Now measure from sternal notch to ear, and the ear to the ET connector. Mark measured spot on tube with fingers. Insert the flexible without suction to the previously marked depth. Occlude suction port to apply suction while withdrawing the suction catheter in a twisting motion. Be sure to suction no longer than 15 seconds. Remove suction catheter, ensure ventilations are resumed, and clear suction catheter with sterile water or saline. Verify tube placement, monitor hemodynamics, and observe for the need to repeat suctioning.